Bonsoir et merci à tous d'être venus ce soir. Je vais basculer en anglais assez rapidement, la conférence dans cette langue. On en reparlera tout à l'heure. Sharon comprend le français, donc pour ceux et celles qui préféreraient ensuite poser des questions en français, sentez-vous libre de le faire dans la langue qu'il vous plaît. Et si besoin, on traduira les questions et les réponses. Voilà, so well, good evening everyone, and good evening to all who are here physically present, and also all of you who are actually following the live stream of this conference. I'm very happy to welcome tonight Sharon Abramowitz for a conference dedicated to the relations between anthropology and humanitarian action. Sharon is an anthropologist and a visiting researcher at Rutgers University in New Jersey, USA. It was the first time for us at CASH, and for me as well, to meet with Sharon, but we had heard of her, followed from a distance her work on Ebola in the last 3 years, but until recently failed, or at least did not succeed to engage. And then about a year and a half ago, I was asked to review a book she co-edited jointly with Catherine Ponterbrick, Medical Humanitarianism, Ethnographies of Practice, so this is this book. And so I did, and I read it, and I reviewed it. And I found it to be a real fascinating book. At times cruel and uncomfortable, but mostly empathetic, benevolent, and quite enriching from a practitioner point of view. A series of case studies, the book's aim seemed to describe rather than judge humanitarian actors' choices. And both the book and the review were then perfect opportunities for us and for me to reinitiate contact with Sharon, which I did in the subsequent months. So today we are benefiting from her attending a workshop in Geneva, an Ebola-related workshop, to have come here and discuss her work with us. What we'd like to take from this conversation is, of course, multifold. First, an introduction to Sharon's work in general, topics she's worked on, her field work in particular, mostly in West Africa and in Liberia, where she has spent most of her field work, as we'll see later with her. Liberia is, of course, a place familiar to MSF and many of us particularly. And then we'll hear a view and perhaps challenge it on the merits of anthropological approach to humanitarian action. The role anthropologists are asked to play by health actors, but also the reception of the anthropological work within the health sector and the humanitarian community as large. As I mentioned earlier, her involvement in relation to the Ebola epidemics was immense, massive, still is, I would say, and so of course it will be particularly relevant to hear what she has to say on that particular topic. But of course, during the second part of the conversation, when the room is open to your questions, we'll be looking forward to widen the scope of the discussion. So now, to make it as short as possible and without much further ado, I pass the floor to Sharon, whom I'd like to thank again to be with us. Thank you, Sharon.
It's really a pleasure to be here today, and I'll be giving a talk entitled MSF Anthropology and the Patient Healthcare Continuum. When Michaël invited me, he suggested that I talk about my research. And I decided that instead of focusing specifically on my research, I was more interested in starting a conversation with you about where we could find common ground. But I understand that many of you are doctors and that time is limited, and so I want to tell you a short story about a rabbi who lived 2,000 years ago named Rabbi Akiva, who was asked one day in sort of a challenging way to explain the entire Torah standing on one leg. And his answer was, "Do unto others as you would have done to you. The rest is commentary." My goal is that By the end of this talk today, I'll be able to do the same for explaining the need for a relationship, a close relationship between MSF and anthropology while standing on one leg. Before we dive in, I just want to differentiate a few core concepts that can often be confused. The first concept that I want to mention is the anthropology of humanitarianism. In my mind, this is the study, often critical, of interventions that are intended to alleviate human suffering in conditions of emergency or crisis, with an emphasis on the role of local populations. The book that Michaël was describing is about the anthropology of humanitarianism, anthropology engaging with humanitarian aid as an external observer. This is quite different from what my colleague Fernanda Falero-Cusano has characterized as humanitarian anthropology. Humanitarian anthropology is work, any work, policy work, field work, logistics, operations, clinical care, that puts people at the center of humanitarian action, thereby improving the effectiveness of overall response. And then, just so that we're all on the same page, coming from the many different backgrounds that we all come from, I'd like to advance an unusual definition of culture, which is basically how people take care of each other. As I said, the rest is commentary. Now, I'd like you all to engage in an exercise if you don't mind. Close your eyes, yeah? Okay. Picture the last person who told you that they weren't feeling well. What did you do? Listen. You listened, yeah? You talked? You talked, yeah? You empathized. Good. I can tell you that the last person who told me that they were unwell wasn't somebody exactly who told me that they were unwell. My 4-year-old son wasn't feeling very well a few days ago, and he let us know that by climbing into bed fully dressed halfway through the day and announcing his intention not to get out until the following day. So the person who informed me that he was unwell was my husband, who's home watching him very kindly. Thank you, Greg. Okay, and what ensued from there is a sequence of care that involves the making of decisions. What we have here is what I characterize as the patient healthcare pipeline. When my son came home and said that he wasn't feeling particularly well, the first thing that happened was the act of recognition. My husband touched his head, noted that he was feeling hot. We observed his behaviors. We did all of the things that you do when you have an intimate recognition of the presence and the experience of someone, and an awareness that the way that they are is a little bit off from usual. This isn't just the beginning of healthcare. This is the core foundation of social engagement from the moment that people are born until the moment that they die. The next step that's taken in the patient healthcare pipeline is action. Sometimes. Often, when people report that they're unwell, a determination needs to be made. That determination usually involves the allocation of resources. Frequently, it's a woman who does the act of recognition, but that can change at the moment of action. Resources get juggled. A parent may get mobilized to take a child somewhere. In our own circumstances, the determination was made that he wasn't sick enough to do much, but that we were going to change our own resource architecture by changing around time and changing around the organization of our routines and changing around the distribution of our labor in order to allow him the time to just rest and sleep through the day and sleep through the night and change expectations, which involved the disruption of routine, which is itself a mobilization of resources. Then, when the situation escalates, there is the first stop. The first stop almost always happens before you get to the clinic. The clinic is usually the last stop in the patient healthcare pipeline. The first stop can involve any number of any number of actors. It could involve your social network near and far, a call to your mother to ask for advice, a call to your sister, calling over your neighbors and asking them what they think. In some situations, it involves going to a traditional healer or a local pharmaceutical vendor. In our cases, it often involves Dr. Google, going to the internet, yeah? And sometimes it involves self-medication. This constellation of the first stop is, for many, many people in the world, the last stop before they get to the clinic, yeah? And then there's the clinic. So I would venture to say that although MSF has many community-based programs, the place where MSF really hangs out on this continuum is pretty much here, yeah? Would you agree? Yeah. Pretty late in the patient healthcare pipeline. Now, of course, every single step of the pipeline is affected by humanitarian contexts. If you take, for example, the location of recognition, sometimes in a situation where people have been forcibly displaced, they don't have anybody to recognize their own experience of suffering because they've been separated from family members. Or people may be so resource deprived that they're unable to differentiate normal suffering from some sort of unusual situation. In the domain of action, the usual constellation of resources that a family or a network can draw upon will be fundamentally altered. And it may not be able to innovate or develop new resource capacities to mobilize. In the context of the first stop, over here, all of the usual places that you go may be unavailable to you. You may lack access to communications. In the context of Liberia, for example, traditional healers were dispersed into refugee camps, and there resulted in a non-reproduction of traditional healer knowledge over the course of a generation that fundamentally disrupted the reliability of traditional healer practices. Google may not be available, and the medications that you have access to may be bad or otherwise inaccessible. And the clinic may no longer be your usual clinic, it might be MSF. So let's talk a little bit about this location called recognition, and let's talk about why anthropology is involved in this and why it has a relationship to MSF. Recognition is where things that are strange are differentiated from things that are ordinary. This is where informal diagnostic processes take place. This is where case definitions can be determined to be correct or incorrect, especially under conditions of novel disease outbreaks. This is where targeting case identification messages become particularly important. This is where getting the person in charge of diagnosis to believe the case ID information becomes particularly important. If you don't have the trust of the person who's doing the first act of recognition, then you don't have somebody who's going to use your case identification and reporting mechanism. This is also the first site of transmission potential. Let's talk about action. Why is action at this point relevant in the process for MSF? This step usually introduces new transmission potential. Step 2, yeah? There is a recognition that there is a problem, but the nature of the problem is not identified. This is an important inflection point in terms of the public health component of the response. Variation among risk to subpopulations are introduced. Instead of being focused within the immediate family unit, the network is widening. People are reaching out and they're trying to mobilize additional resources. As I said before, resources are being mobilized to address a perceived problem. This is really important to know. In the context of case identification, surveillance, and outreach to people who are experiencing whatever MSF is trying to target, identifying the situation where people are mobilized to advance resources to solving a problem is a really key inflection point. There is will and capacity to find redress for the unknown problem, and this is when the problem usually moves outside of the household. First up, okay, why is this point in the process relevant for MSF? This step involves key actors in the healthcare worker pipeline and shows where people fall off the pipeline. As I said before, even when there's a healthcare facility at the end, many people stop here, like for example in the context of mental health, when they're using substance abuse in order to address, symptoms in general, okay? Or they seek out the support of traditional healers, they seek out the support of informal network experts, and they try to resolve the problems for themselves, yeah? This is good, right? It's not bad that there's a first stop. Not every single health problem that everyone has needs to present itself to a clinic, right? Not every problem requires a clinical intervention. It does introduce new transmission opportunities. It introduces new opportunities to stop the transmission of disease through key knowledge brokers. It introduces new opportunities for surveillance and contact tracing during epidemic events. And it allows for the identification of unexpected high-risk populations. One example would be, for example, in the context of the West African Ebola epidemic, there's a lively informal trade in body preservation fluids for the purposes of funerals. And the people who engage in these trades are often expected to use the fluids to support body preservation. This isn't a part of the traditional burial structure. It isn't a part of the formal burial economy. It is an informal segment where transmission was likely to occur, okay? So it also picks up informal healthcare workers, private healthcare workers, and as I said, other forms of body handlers. In the clinic, why is this point in the process relevant for anthropology at MSF? This is where anthropology talks to MSF all the time about the things that MSF should be paying attention to, right? So I'm not going to belabor the point. This is where you get into baseline cultural competency issues. Gender, religion, privacy. But it also gets into basic issues about sensitivity to issues that impact community trust. For example, transparency. What happens to people who use healthcare services? Community concerns about what happens to people who use healthcare services. Security. Are people in the clinic having their basic needs met, and are they being harmed? Accountability. Is clinic staff going to tell community members what happens to their families and friends who use the clinic? And rumors. Is the clinic involved in webs of risk that pose dangers to the community? For example, military engagements, financial engagements, medical or clinical testing experimentation, international engagements. Now, the reason that all of these things are really important, and I'm just going to back up a bit, is because over here, this is the foundation of culture. Culture is based on trust. And if you break trust by violating any of those issues that were just mentioned at the clinic level, it's going to be longer and harder to do your work. It takes more time and more effort to rebuild trust once trust is lost than it does to maintain it in the first place by having a proactive engagement with community concerns and community values. What I'd like to do right now is I'd like to give you a few different examples of the ways in which I, as an anthropologist, have engaged with some of these issues. Okay? I didn't want to give you a long list of the kinds of research and the kind of work that I've done, but I think it's important. I think it's important to recognize that anthropologists have the ability to wear many hats simultaneously. They're capable of wearing an intervention hat, an operational hat, a critical hat, and of course, a community-based, field-based hat, yeah? So I'm just going to tell you a little bit about the field work that I conducted in West Africa. When I was conducting my dissertation research, and for a while afterwards, my work was focused on the mental health and psychosocial needs of Liberians who were experiencing the post-conflict recovery. The work that I did was focused on identifying what options were available. Initially, I went to study post-traumatic stress disorder, like many anthropologists do. But I found that what was present in Liberia was a very complex environment of mental health service delivery, and in some cases there wasn't service delivery at all. So I ended up paying attention to the services that were available to people who experienced major psychiatric disorder, and the people who were identified as having high-functioning mental illnesses with psychosocial distress, the usual package of baseline anxiety, depression, PTSD, things like that, maybe some obsessive compulsive disorder. Now, this is kind of what the usual triangle looks like, right? And we assume that there's some borderline cases, right? But we have a bit of a problem in terms of understanding what this borderline case area suggests. And what I found in the context of my research, which also included looking at other areas in which people experiencing mental health problems showed themselves to the response community, like gender-based violence interventions, is that what we usually think of as the knowable borderline cases area probably fits into this component of this triangle, and that within many post-conflict communities, there's an enormous area of borderline cases that are never identified either at the community or at the clinic level, that are being maintained through access to substance abuse and alcohol. Now, when we're talking about substance abuse and alcohol, we're not talking necessarily about heavy drugs, but what we are often talking about is consistent use of marijuana, diazepam, and other kinds of self-medicating behaviors, yeah? So, in the book, I ended up talking about mental health and psychosocial services and barriers to care, right? So, I am not going to go too into detail about this, but what I can tell you is that when we usually think about the services that are available to people with mental health disorders, we think about inpatient or outpatient psychiatric treatment and stabilization, preferably with community-based support. And we think about this domain of interventions: outpatient care based at primary health units, mental health and psychosocial counseling, individual counseling, group counseling, gender-based violence counseling, and in the context of Liberia, ex-combatant reintegration with or without mental health and psychosocial services. So the question becomes, where do these borderline cases go? They either go up or they go down, right? But there really aren't any services that are targeted at borderline cases, especially not at the borderline cases that are hidden by substance abuse and alcohol in a way that allows them to maintain minimum standards of socially perceived functionality in their local communities. So social functioning and the interaction with drug and alcohol abuse is an important part of modifying our understanding of what the space of need is and what tactics need to be taken in order to identify latent mental illness in communities. Now we're going to move into another phase of my career, which was exemplified in the book, Medical Anthropology, Ethnographies of Practice. It's critique. The space of critique looks at the clinic. Hello, so you see the little heart? And the population, right? And it considers this population-clinic relationship in the context of other factors: finances, international preoccupations, and this is my version of a Ministry of Health building, okay? And the space of critique looks at how these factors impinge upon this relationship, and also how this relationship speaks to these factors. I want to assure you that the space of critique is not intended to be, I know it may feel the opposite, but it's not intended to be a direct critique of MSF, as though anthropologists don't like MSF. I think that the purpose of critique really is to try to understand the broader forces in play that are shaping MSF's ability to do its work. So the article that I wrote in that book, which is the reason why I even ended up assembling that book, was entitled What Happens When MSF Leaves? And the focus of the article essentially asked the question, what was happening around MSF's decision to leave Liberia in 2006-2007? When MSF decided to leave Liberia at that time, there was a tremendous amount of consternation and an internal debate ensued at MSF that resulted in a decision being made that MSF was really needed for emergency response. Liberia's war had been over for 3 or 4 years. They were no longer in a period of emergency, and it was time for the Liberian Ministry of Health to take over responsibility. This actually created a bit of an international crisis in global public health service provision. In the aftermath of MSF's decision to depart, all of the remaining NGOs that stayed in Liberia ended up having to appeal to the international donor community to demand additional funds to fill the public health space that MSF had left empty. Local communities were changed in significant ways by the departure of MSF healthcare services. And a substantial debate ensued between donors, healthcare providers, and local populations about what real sovereignty means and what sovereignty means in terms of the state's ability to provide healthcare. Does a state need to be able to provide its own healthcare in order for it to be sovereign? Is the being able to provide healthcare to your population a condition of sovereignty? This resulted in what sort of it was an unintended finding, but it was an interesting finding nonetheless. By shifting the frame of the analysis of MSF's engagement in Liberia, I discovered that MSF has impacts on local contexts that far exceed its intended humanitarian intent. And what this chart shows you, and this is actually based on MSF's annual reports, is that MSF expenditures in Liberia just for national staff from 2004 to 2011 amounted in 2004 to 4.5% of the total gross national income, which is pretty enormous, yeah? It was a very cash-poor situation. Now, MSF's withdrawal happened right here when it dropped from 3.5% to 2%. And by 2011, you can see that the gross national income had been less dependent on foreign direct transfers of cash through the form of national salaries. Now, I know that this this question isn't really a part of MSF operational planning or decision-making about withdrawal, but it is helpful perhaps for MSF to consider the role that it plays in economic stimulus in post-conflict environments that have significant cash scarcity. I personally don't see that there's anything really wrong with this dynamic. I personally think that the role that organizations like MSF play in advancing a Keynesian economic stimulus in cash-poor environments in the aftermath of massive conflicts or epidemics can in fact be quite constructive. One could even think of it in terms of redistributive justice. But that is not a stated part of MSF's intent. It's not a stated effect that people are particularly paying attention to when they're studying post-conflict transitions in healthcare sectors. And it's worth noting exists. And I don't know if it has direct implications or not, but it could have implications for how MSF thinks about human resources, policy and planning, and a range of ethical issues, including staff payments, etc. Now I'm going to move into the part where I talk about my role in the Ebola response. And here we have the world, and here we have the community, and here we have Ebola. And my role in that was to try to get the world to understand what the community was thinking, doing, and feeling, and responding to, and to get the community and to support communities in accessing the world's resources at a very difficult time. I was involved in an array of activities related to Ebola during the Ebola epidemic, most significantly leading the American Anthropological Association's Emergency Ebola Anthropology Initiative, which established a global network to move anthropological information into the response, support anthropologists who are in the field, and try to pull information out of the field for rapid analysis in order to return it to the response. I'm not going to go too into details. We can certainly talk about this during the discussion. But what I do want to address is what all of these articles meant to do. Basically, they meant to address questions that started with the word how. How quickly can communities learn new messages during an epidemic? Is it very, very long, months and months, or years and years, as some were saying at the beginning of the Ebola outbreak? Probably not. My findings suggested that people could adopt new messages and adopt new practices in under 2 weeks, although they were likely to discard practices that didn't work in the context of their daily lives. I also found that people could adopt new practices at the same time that they retained hold of contrary beliefs and rumors. How quickly can communities adopt new practices? In the absence of other supports, how did communities respond to the Ebola epidemic, and how could the latent structures that they put into place be supported rather than having an entire international response move in and try to set up infrastructure from scratch? That includes communications pathways, transportation pathways, self-imposed hierarchies for monitoring movement within and around communities, case identification, support for quarantines. I mean, the list goes on and on. I asked, how are communities dealing with issues of non-Ebola morbidity and mortality? And I found that there were other possible vectors for Ebola transmission and also Ebola case identification in semi-expert informal healthcare domains that were generally unrecognized by the international response. For example, black baggers, pharmaceutical vendors. There's a widespread but small money market in hiring people to provide insulin injections on a week-to-week basis, right? Those people were high-risk communities. They were dealing with blood. They were coming into contact with people who were not feeling well, but they weren't engaged as part of the response, as being at all a part of the overall healthcare infrastructure. And I asked, as part of this network, how anthropologists could get information into the response without disrupting operations. How do you make anthropological information operationally relevant? This is a really hard question to answer. In the post-Ebola period, this work has moved on to try to understand why it is that social and behavioral sciences, that's SBS up here, does or doesn't speak to the work of medicine and epidemiology. In partnership with David Hipgrave in UNICEF's Health System Strengthening Program, we developed a parallel systematic literature review where we did a systematic literature review of the entire literature on Ebola epidemiology, and we did a systematic review of the entire literature review on Ebola from the perspective of social and behavioral sciences. What I can tell you is that doing an inductive thematic analysis, we found 42 major themes and probably somewhere between, I don't recall right now, but around somewhere between 180 and 220 sub-themes that were addressed in the two literatures. It's also, perhaps unsurprising, that the two literatures did not really speak to each other very well. This shows an analysis of a comparison of the epidemiological and SPSS literatures, and I've highlighted addressing clinical issues, okay? This shows that epidemiology, big surprise, was much more concerned with clinical themes, and that anthropology was somewhat less concerned with clinical themes. The sub-themes that were addressed under clinical care were ETUs, ETCs in hospitals, community care centers, Ebola signs and symptoms, patient care, supportive care and fluid replacement, intake triage, treatments and therapies, clinical outcomes, and issues of readmission. Now I'd like to compare this with the social and behavioral sciences' attention to alternative health practices, where you can see that the epidemiological literature did not have very much engagement, other than perhaps mentioning it a bit in introductions and conclusions, but the SBS literature paid it a lot of attention. This addressed issues of self-treatment, the presence of midwives or traditional birth attendants, household-based caregiving and caretaking, private healers, traditional healers and herbalists, local health-seeking behaviors, and the issues of pregnancy and labor that were perhaps specific to the West Africa Ebola context. Now, it's worth noting that these alternative health practices pertain very much to the first, second, and third boxes in the patient healthcare pipeline. And the clinical and epidemiological, mainly the epidemiological literature was mainly focused on the fourth station. Now, it's interesting to consider what would happen if we could integrate all of those in the context of a humanitarian and public health response, and all of the patients that we could help, and all of the ways in which we could improve overall service delivery and prevent suffering. Yeah? I know that we have a lot to discuss. I've been warned in advance that this is a group that likes to have a lively debate. I just kind of wanted to advise you that moving forward with integrating anthropology into humanitarian response in any capacity is going to take a lot of work. We need, among other things, and I can talk more about this, to develop qualitative indicators, or even better, indexes of qualitative indicators that can be integrated into epidemiological modeling. We need to develop tools for anthropologists to streamline their work. We need to build out networks to support anthropologists and social scientists working in the field in the same way that clinicians have access to external resources and information sources when they're operating in the field. There's a certain degree of professionalization that needs to happen in the field of anthropology in order for it to be able to well integrate it into a difficult operational environment, and in order to train social scientists to really understand how to be of service to a non-social science outcome. There needs to be new training mechanisms that are developed on both the clinical side and the social science side in order to better tie together the integration of what doesn't exist yet but could be conceptualized as social science policy in order to translate knowledge into practice. And this is actually an image of a WHO deployment training for social science interventions and emergency response that was just conducted last week. 24 social scientists from around the world were brought to Geneva and were put through 8 grueling days of WHO training in the emergency response framework and in deployment. And what you see here is the trainees' engagement with somebody who is pretending to be from MSF. I also want to mention that I am well aware that there is a number of existing resources on anthropology, qualitative research, and community engagement available to the MSF community. Among the MSF experts that I know are already actively playing a role in trying to integrate humanitarian anthropology into overall MSF operations includes Fernanda Falero Cusano in Spain, Doris Bircher in Vienna, Beverly Stringer in the UK, Emily Venables in South Africa, and Carleen Abusada. Okay? There's a number of guidebooks that have been developed around establishing dialogue between MSF, its patients, and communities, a guide to using qualitative research methodology, and a guide for involving communities, and I wasn't able to include it here, but there's also a really important ethical framework that's been developed for internal use for MSF that allows for the rapid approval of qualitative research in field settings. And this actually sets an important template for other innovations that need to take place more broadly and more widely in the field. So, following up on my promise, I'm going to stand here on one leg, and I'm going to say that my final message is that that to give good health care to as many people as you can, quickly and well, you have to learn how people take care of each other. And I'll also add, for good measure, that humanitarian contexts change quickly, but frankly, culture does not. Culture has a stickiness and a persistence about it. Horrible things can happen. Epidemics can emerge. Wars can take place. Genocides can happen. And culture has the ability to persevere if communities are engaged to allow for the preservation and the sustainment of their culture in the context of those difficult circumstances. And I think I'll stop there. Thank you very much.
So for the second part of the discussion, I'll take a bit of my position here to maybe ask the two first questions, but then I'll happily end the floor to you. There is a mic. If there is a volunteer to pass the microphone around, please show up. Thanks. No, you were on time. That's perfect. You offered the first question on the plate, like really, you offered it to me. I think you said anthropologists don't like MSF, and so I was curious to see why do you think that is?
Huh? Sorry?
I think you said that anthropologists don't like MSF?
No, I said sometimes. Should I use this?
Yeah.
Okay. I think that sometimes there's a perception that because MSF is used frequently as a case in critical anthropological studies, that there's an eye towards, putting MSF in its place or teaching it a lesson or only looking at the bad instead of looking at the good, yeah? But I think that that's not really the intention. I think that actually MSF has a huge fan base in the anthropological community, an enormous amount of admiration for what it is that they do. But I also think that anthropologists are concerned with how MSF fits into the broader constellation of actors in emergency settings.
All right, well, there will be probably hundreds of questions following, but the one question I'd like to ask you to start with is, because you finished by talking about Ebola, and we had a number of discussions here about Ebola, and I think our last crash conference was on Ebola. And it focused very much on the quality of healthcare provided to Ebola patients. Ebola, as an epidemic, was a scene of massive involvement of anthropologists in comparison with other humanitarian interventions that some people may have in mind. Numbers of people deployed, hundreds of papers written after those deployments. What do you make of all that? Kind of below, first, why do you think that was the case of so much anthropological interest to Ebola, and what can be concluded of the work that was provided by the anthropologists during the epidemic? Thanks, and then I promise I'll shut up.
There was an enormous anthropological engagement with the West Africa Ebola epidemic. There was a few factors that went into that. One was fairly early on, I would say sometime around April or May of 2014, there was support provided to a group of anthropologists in the UK who developed the foundations of a network called the Ebola Response Anthropology Platform, which was actually the first formal institutionalized funding for the dissemination of anthropological knowledge into an epidemic response. Importantly, under the leadership of Melissa Leach and Melissa Parker with Peter Pio, a determination was made that qualitative findings would be given parity with quantitative findings in some key areas of decision making in the UK government. I think that this set a certain tone. I'm not exactly sure of the details behind it, but I know that within the French government, resources were reallocated from major projects to focus anthropological attention on the Ebola response. And then on the American side, things were a fair bit less organized. Social science is very large. The anthropological community there is very large, and it's not very well integrated into US government operations. There's no phone number of the anthropologists that you really can call to engage with somebody for a humanitarian emergency or an epidemic response. But I think that what you saw there was a fairly sizable community of social scientists who had friends and people they loved who were in West Africa, people who had been working in West Africa for many, many years, and were listening to the media that was coming out of the response, and were observing the decisions that were being made about the response, and were frankly shocked and horrified and moved to a strong position of advocacy. I think that what ensued from there was a powerful paradigm of coordination based on networks that prioritized open access to data, collective sharing of information, and basically a disregard for the usual conventions that tend to undermine academic collaboration. People agreed to not care about attribution. People decided to not fight about owning data. People decided not to worry about publications. And there was a certain discipline that was applied through several different processes, but one of which involved the development of briefs, using collections of anthropological knowledge that we provided to UNMIR, that were really focused on just trying to make anthropological information as useful for the overall response as possible. That being said, I mean, I think that the response was highly visible, but I think it was relatively small. You know, I've done some back of the envelope analyses, and I've found that probably the total amount of expenditures spent on anthropology in the Ebola response was somewhere less than $2 million. And in terms of actual field researchers, I would venture to say, knowing many of the key actors who were involved, that it probably came to fewer than 30 or 40 people. So it happens to be an unusual situation in which the perception of the impact of a particular discipline far outpaced the actual size of their engagement in the response. And of course, far outpaced the amount of resources that were allocated to it. People were working for free, they were working through the night, people gave up their sabbaticals in order to just work on finding Ebola information and processing it. I think that what I learned about the anthropological community is, I mean, among other things, I admire them greatly, you know. And I think that what we saw was a non-professional, deeply personal commitment to trying to help. But I also learned that there was no infrastructure for supporting that kind of help. And without an infrastructure, anthropologists could be producing profoundly insightful information about the mobility of populations, transmission potential, risk communities, issues about the accuracy of information that was being provided to local populations. We had information, for example, about the fact that social mobilization teams were being used by local communities for case identification and contact tracing, but they were only being trained in social mobilization and weren't being given any support for case identification and contact tracing. Yeah, I mean, there were significant response gaps. And when we identified these problems, we had a lot of difficulty. There was no fixed way to feed that information back into the response. And the last thing that I'd say is that I learned that the anthropological community has a long way to go in terms of learning to make itself operational. They need training, and they need access, and they need engagement in operational priorities in order to learn how to translate knowledge into practice, how to translate knowledge into immediate response action. And they need a better understanding of the context of healthcare. Most anthropologists who engaged with the Ebola response are not medical anthropologists. They're political anthropologists, economic anthropologists, anthropologists of food. It's anthropologists of humanitarianism. Many of them well, maybe I'm speaking for me at a certain point, but, you know, would have had difficulty differentiating bacteria from a virus, you know? And that is something that can be easily remedied. These are highly trained people, and they're highly intelligent people, in fact, but that's just not where their skill set is. Sorry. And I just want to mention one more thing, you know, for the purposes of this audience. Most people who identify as anthropologists have at least a master's degree, if not a PhD. Yeah, there is nobody who characterizes themselves as a medical anthropologist who has not been trained and vetted to gather information on this recognition to clinic pipeline. This right here is the minimum standard for becoming a PhD in medical anthropology. This part is usually the work that many medical anthropologists do after they finish their PhD, right? So this part is as natural to medical anthropologists as writing papers, I suppose. I don't know what's natural to medical anthropologists. But how you integrate this into an operational architecture that's concerned with other priorities, yeah, we're not quite there yet.
Thanks. So, questions? I can give you a few more minutes to think of your questions, and then I'll ask another one. I mean, you've been clearly, and for good reasons and good measures, I guess, advocating for a smarter use of anthropology within humanitarian action, and also deeper and more involvement. We had a conversation a bit earlier, but the fact is that many disciplines within the big social sciences domain might come with the same request as I can be useful. A geographer could be useful, an historian could be useful, an economist could be useful. And it's quite clear that in the context where we work, it's hard to see how an organization and a project can equip itself with all these disciplines. And actually, empirically, MSF has been working without those specialists in all of its interventions, and that has not been a total failure, or at least a systematic failure. So how would you then pick and choose those interventions that you think do require a particular expertise from anthropologists, for instance?
I wouldn't. I think it's situationally dependent. I think that, listen, anthropology is a disciplinary pursuit, and it's prioritized. I mean, it's concerned with people, and it's concerned with understanding people. But I think that anthropologists, as a pool of people, come from a range of really weird backgrounds, yeah? There's a lot of lawyer anthropologists, doctor anthropologists, epidemiologist anthropologists, demographer anthropologists, geographer anthropologists. Me, I'm a sociologist, anthropologist with epidemiological training, right? It's an approach. Right? And it's an approach that can be coupled with other approaches. But I think that it's the situational context that determines the best plug-in fit for the engagement of this sort of social science space that uses a qualitative understanding of how in order to make the who, what, where, when, and why better. And I think that is something that an anthropological approach is uniquely capable of doing. And I think that one of the reasons why anthropology ended up taking on a visibility that far outpaced its actual scale in the context of the West Africa Ebola response was that there were many people in the field who were not anthropologists, but who identified with the lens of anthropology, who believed in a standpoint of community engagement, trusting local communities, building upon existing resources, human rights, and respect for human dignity, and put themselves sort of in the anthropological slot. I personally was in contact with people from all of those disciplines and all of those domains who adopted this anthropology identity. And it carried over into the ways in which people thought about the work that they were doing in the clinic, in community outreach, in psychosocial care, even eventually in surveillance, yeah? And so I'm not here advocating per se for creating a job for an anthropologist on every deployment team. I don't think that that's necessarily right, and I don't necessarily think it's appropriate. But what I do think is that we don't have an evidence base for knowing whether or not social science interventions in the entire architecture of humanitarian response save lives. And we don't have an evidence base to show that they don't. But I think that it's a tool that was identified, and you know, for many, many years of humanitarian response, we've been okay with just not knowing and using it as we kind of think it might be helpful. But I think that it's time for us to know. I think it's time for us to roll out a serious field of inquiry where we engage substantially with the social science community broadly. And integrate them into the center of humanitarian response from the beginning. Don't wait until there's a problem to bring them in to solve it. You know, bring them in from the beginning and put into place mechanisms to see if this makes things better. Because what we have going on right now, in many respects, doesn't work very well. Yeah?
Thanks. So again, feel free to ask a question in French if you prefer, and whenever possible, identify yourself. Thanks.
Bon, alors je vais parler en français, tant mieux. Merci pour la suggestion. Donc je suis revenu, je travaille au crash avec Michaël et les autres. Je n'ai pas très bien compris ce que vous disiez sur le retrait de MSF du Liberia. Je reviens donc avant Ebola. Est-ce que vous tirez un diagnostic sociologique ou anthropologique du retrait de MSF? Est-ce que vous avez une recommandation à faire? Ou est-ce que vous estimez que c'est un échec, enfin que le retrait efface l'action que MSF a menée précédemment? J'aimerais savoir ça d'un point de vue, évidemment, enfin de votre point de vue, disons, de sociologue, anthropologue.
What? Okay, I understood, yeah. Okay, as far as I understand, you're asking me if I have a specific recommendation about my critique of MSF's withdrawal. Yeah? My recommendation would be that at present, I understand that MSF internal debates shape a lot of MSF policy. I think that MSF debates need to reacquaint themselves with what they mean and what they intend by the term sovereignty, right? I think that there's that the definition of sovereignty that MSF is deploying and making decisions about when is an appropriate time for a state to take over the operations of its own internal healthcare sector it's problematic. Yeah, I don't think that it's well aligned with the reality of circumstances on the ground, and I think that it's entirely up to MSF to make this decision, but I think that MSF should consider taking into account the public health impact of its departure and the economic impact of its departure, as well as the other competing mission priorities that may be taking place elsewhere in the world. The other work that I've done on...
Let's suppose we've taken this into account.
Yes.
And we leave anyway.
Yes.
So what difference does this make?
Well, it makes a lot of difference to people who live in Liberia, for example. But you know, I mean, if you leave, bye. It's your decision, yeah. I mean, and the argument that I actually make in the book is that when MSF makes a determination about whether or not to enter into a situation, there's many factors that do bear upon that. But MSF actually has a remarkable degree of freedom in terms of making decisions about when to leave, right? It's probably the only part of MSF's entire process where it's really unaccountable to anybody other than its own internal decision-making structure. That's not necessarily a criticism, but it's an observation, yeah? And I think that perhaps this process of departure is something that should be more closely looked at. And the specific case that I addressed includes this one quote from somebody, from an MSF logistician who was left behind to kind of clean up, yeah? And he said, listen, we've been in Liberia for a very long time. And when Liberia needs us again, we'll be back. And he was speaking specifically of a location in which MSF ended up having to build one of its largest ETUs in all of West Africa, right? So if you look at MSF's decision to withdraw in isolation, you can go where you like. You're an independent organization. You're accountable to yourselves, right? But when you look at it in the context of leaving before there's an effective surveillance apparatus that's put up in a place where an epidemic outbreak can happen, where there's no government capacity, where the humanitarian organizations that are left behind are left kind of, you know, I don't know, holding the healthcare bag, yeah? I mean, I think that there's ethical and policy questions that can be asked of that kind of a decision.
Right. Just to go back to the discussion about incorporating this anthropological approach into all our operations. So, I mean, in practical terms, have you got any tips of how we could go about that? Because, for example, you say an anthropologist will normally have a master's or at least a PhD. Some of us are lucky enough to have MSF pay for our masters, which is nice, and then we come and work here and we're not in the field anymore. So in terms of the general day-to-day person who's actually managing that project on the ground and trying to instill this anthropological approach into our teams as a background, how would you sort of suggest that would happen?
Yeah, thanks for the question. It's really good. I think that, gosh, I mean, social science is a large field, yeah? It's like asking, like, how would you integrate medicine into a response? Yeah, like you integrate medicine into a response and you figure out the details later. So, I mean, I can give you a few different examples. One example that I could give you in a non-Ebola context, right, would come from post-conflict Liberia, where in the context of the anthropological fieldwork that I was doing on gender-based violence, for example, I became aware in 2005 that there was really an epidemic level of sexual and gender violence that was being used against children ages 6 to 10 years old, right? So that was something that had kind of become visible at that point. To this day, the problem continues. I don't know why it is happening. I don't know how it's happening. I wasn't able to do that research. But I know that it was becoming a priority for MSF in 2007 when clinical nurses were being presented in one hospital with 10 of these cases a day. Yeah? So I would suggest that social and behavioral sciences have the ability to a very limited extent and with substantial contextual knowledge, anticipate, identify problems early, and do a bit of forecast and prediction, yeah? They also have the ability to identify latent community capacities that aren't otherwise being tapped into in order to make our response more stronger and more robust and more publicly acceptable. And the way in which that works happens in an array of ways. If we are talking about the Ebola context, for example, you mentioned the debate that was had about the quality of clinical care that was provided at ETUs, right? There was a widespread perception among local communities that the quality of clinical care provided at ETUs was not okay. And that some of the basic sort of human rights and human dignity issues around accessing family members at ETUs was not okay. And the messages that were coming back to those communities as part of the broader international response, which, like it or not, MSF was in fact a part of, was very critical of those local populations. It even went to the extent of calling them myths, rumors, superstitions. You know, essentially, you know, it was a rare form of international gaslighting. Yeah? And I think that, you know, the presence of a social and behavioral scientist on the team might have the ability to look at the operational construct, perhaps from the very beginning, and say, let's start off by, by being honest, yeah, and by prioritizing the respect for human dignity, for the foundation, for foundational relationships that structure social life, for the natural social dynamics that people use in order to engage in complex communications and movement across a large area in this very complicated situation. And let's build our response on the basis of that, right? It doesn't actually involve, I mean, honestly, some of this is just reframing what's already there. It's a pretty low-cost intervention, but it can have, I believe, and we don't have the evidence to support it, we need evidence to support it, it can have significant impacts. I also want to mention, if I may, that there needs to be, that social science interventions don't need to just happen on the ground, right, in the context of the field or on missions. There needs to be an integration of qualitative data into epidemiological modeling. There needs to be some substantial work that's done to develop indicators and indexes of indicators that allow for contextual variables. Perhaps one index being, knowledge, attitudes, practices, something like that. And another one being, the effectiveness of the overall response. And have those, qualitative indexes be integrated into reporting capacities. Have them be mandatory. Have them be integrated into the OSHA SITREP structure, right? And then you'll be able to develop an architecture where you can measure outcomes. You can look at, for example, if you can sort of have, if you imagine like a CAP index, right? That's being collected using a wide range of really interesting technologies that are emerging on the field. If you're collecting CAP data on a weekly basis and you're creating a minimal capacity for analysis and it's being fed into, like a CAP thermometer that goes up and down and can be modeled to identify where practices are having issues, where reporting is having issues, as opposed to places where things are going really well. Subpopulations that are having access to information, whereas other subpopulations are not. This would be a big deal. It would be a really big deal. If you look, for example, again at Ebola, you saw a real qualitative difference by gender, not in the overall number of cases, right? At the end of the day, the overall number of cases by gender was roughly equal. But what you saw was that women had access to different pathways of information than men did. Women used household visits, community meetings, and diaspora feedback. And men used media and community leader engagements for major pathways of engagement. That's really important information, which could be, cultivated in that way. You also saw very different pathways by gender in terms of risk to transmission, yeah? Women were doing the majority of direct healthcare provision within households, but that didn't protect men. Men were responsible for extra household aspects of the patient to healthcare pipeline, and that put them at risk. Transporting people, mobilizing resources, doing community protection and things like that. These kinds of factors, somehow, there needs to be a set of tools that are developed so that these factors are immediately integrated into epidemiological analysis on a rolling basis so that it can help determine real-time resource allocation decisions.
Just a couple of things. I guess one of the things I'm just reflecting is that anthropology doesn't have a neutral history, at least not in my part of the world. You should try talking to the government in Papua New Guinea about anthropology. But also, just reflecting also on Ebola, like for example in Sierra Leone, the government imposed very strict measures which from a sociological point of view clearly were going to be difficult for communities, whichever community you came from. And I'm just wondering, given the difficulty you had in thinking how you impact on operations, but at a higher level, do you see any way that the experience in Sierra Leone could impact on, future management at a sort of public health government level? Because often that restrains even what we can do, not always, but I saw some very good, some useful things about anthropology in Sierra Leone at the same time, but it was sort of after the event in a way.
Right. So to address the colonial underpinnings of anthropology, there's some pretty strong colonial underpinnings of medical humanitarianism too. Yeah. And I think that the way that you deal with that is the way that you deal with that, by putting governments at the center of a response, by doing your work well, by knowing your values, yeah? Being focused on being humanitarian, on sustaining ethical engagements inside the clinic and outside of it, by being committed to human rights and human dignity, and by supporting the empowerment of local populations. At the same time, you're correct, an epidemic outbreak is not, and some of my colleagues in the field, struggle with this. It's not exactly a time for, consensus-based democracy, yeah? Epidemics are many things, but they are rarely democratic, and that's probably fine. I would agree that anthropology did many good things in the context of the Ebola response, in that it came quite late. And that it was operating under a difficult set of conditions. But I think that there's work that needs to be done to put systems into place to ensure that anthropology is integrated earlier so that it can be more effective and work better within the structures and systems as they are on the ground. And I think that any anthropologist who comes in to do humanitarian anthropology is going to have to deal with the reality as it is. They're going to have to deal with the conditions as they are. And yeah.
I have a question. I don't want to put anyone on the spot, but I have two, at least, program managers here who asked for anthropological interventions in the respective programs, and I wanted to see if either of them had any contribution to the discussion as to how actually they decided to work and for what purposes. So, I don't know. Not giving a name, but...
I am one of the two.
So, Pierre Mandiarat, you cited the microphone, please.
Yeah, I was not one of the two then. Bon. We've been using quite a few anthropologists in the past years. I don't know if it's more than before or not. A lot in epidemics, TB, HIV, but not only, as well to work for a certain population. And we were discussing about it these recent months, and we were telling each other that it would be good to try to think about what have been the... Did it work or not? Did it help us? We suspect that it was quite unequal, the quality of the intervention, or at least the outcome of the intervention, of this intervention for our operations. We already started a discussion, by the way, at the last coordinators week about that topic, but I think we're wondering how we could how we could evaluate or think if it was overall useful, and even if it's possible to come back retrospectively on this intervention to have an opinion about that. And all of it without involving another anthropologist, or should we absolutely involve another anthropologist? That's the question I'm asking myself at the moment. Maybe you can help me with some tips?
Yes. Yes, you should hire another anthropologist. No. Sorry. I want to go back to this definition, yeah? Over here, this idea, excuse me, this idea of humanitarian anthropology as being work, yeah? What kind of work, right? Usually, the default response in a situation like yours where you hire an anthropologist is, we're going to bring in an anthropologist and they're going to do a study, right? maybe we could think more broadly about this, yeah? Maybe we could think of like a few different kinds of work that anthropologists engage in that are in fact associated with some sort of outcome indicators, either qualitative or quantitative. You know, we could formalize this, we could professionalize this and systematize this so that just like anybody else in this room, anthropologists have a set of, you know, fit for purpose, contextually appropriate tasks that they need to perform that have outcomes benchmarks, right? The outcomes benchmark should be probably appropriately aligned with the inputs that they have in the context of the situation and so on and so forth. But I think it's interesting in the context of MSF that frequently anthropologists get this weird free pass, right? Please come and do a study. Thank you very much for your study. What do we do with this? Yeah? And I think we need to get out of that paradigm. Anthropologists need to get out of the paradigm, and MSF needs to get out of that paradigm too. If anthropologists are going to be operationally integrated, then they need to be operationally integrated, and that means participating in a particular set of task structures and being accountable for them. I mean, it's just that. What that is, I think, remains for development, and I think it's organizationally specific. I can tell you in this WHO training, we were very much in the process of developing that for WHO last week. Yeah? And what that's going to look like for MSF is going to be very different than what WHO comes up with, right, for itself. But that's probably where we need to go with it.
Yeah, Mathilde.
So I know, I'm the second one. Mathilde, I'm working in the operation, and I have at least 2 examples of work with anthropologists. One which is more or less what you described, sending someone to do a study, and after it was descriptive, so it was in Malawi to know the particular habits in terms of the ceremony of initiation, and how it was for us to realize that, to see in the adolescent and in the young children some specificity that we have to address for the risk of transmission. And it was before we started the project of mass circumcision. But the anthropologist came a few months, give a very, very interesting report. After, I don't think whether it would have really changed the way the project was functioning or the activity were made if we didn't have this deep study. Another experience, which is a little bit different because we are working together since more than 2 years now. It's with the lady who is here, whose name Mitra Asfari, and she's from Iran, and we solicited Mitra for a project where we have a very special population. Iranian drug users, homeless, transsexual people, but also a group of Iranians whose name is the Gorbati, which is not Iranian, which means strangers, so it's like a gypsy. And our team is confronted with all this population, and I like your conclusion at the end in the last slides where you say culture remain. The problem I think we face in our program is that the medical culture of our doctors remain very strong. The patient have to be compliant, the patient have to behave well, the patient have to understand what we tell them, and the patient have to be the one who change. If they are not cured, how can we change them? It's the way we hear all the time this from the national staff. And because the operational choice is to address the needs of those people that nobody take care. I think maybe you know the MSF là où les autres ne vont pas. but in Iran, it's really ceux que les autres ne soignent pas. If I have to define our target population, it would be that. It would not be the homeless, the losers, it would be ceux que les autres ne soignent pas. And really the interest to work with Mitra, it's to be on the long term. I think to solicitate at some moment for field investigation, then to make the feedback with the team, then to ask her to evaluate the interaction with the team and patient, and then to come back. And I hope we will continue to work for some time, because the change will not happen very quickly, and we don't expect the change. We just, at least the change could be in the relation between the doctors and the caregiver, but it's part of a teamwork. The coordination need to understand also how to transmit the message to the team, to the field team, to the national staff, and it's not only how to pass message to the population and how to make this population understand. It's really the mirror between the two communities, our medical doctor community, soignant community, and those community. But I think in the two experiences, the big difference is that it's the timing and the duration. And thank you for all your quality of your work.
That was lovely. I think, I've heard a few stories of people being sent to the field, being there for 2 months, 4 months, 5 months. I personally believe that it is entirely possible, if you hire the right people, to do a quick and dirty anthropology, right? 2 months, 3 months, 4 months, 5 months is a long time, especially potentially if you're about to start a program in South Africa and you hire a South Africa expert. Presumably a whole bunch of that expertise should already be under the belt. So I think that there's a human resource role that needs to be played here in order to expedite the ultimate integration of a person into the rapid functionings of a mission. I also think that this is a wonderful case study, that could be used as an example for how to integrate anthropology in the response. But I also think that Mitra, that Mitra, just as everyone here is part of a broader community on mission, in country and out of the country, of people who can support and provide guidance and provide tools. Mitra deserves to have that too in order to support the overall activity, or the overall program. And right now, there is no such infrastructure in place to support social scientists who are operating on missions. That capacity needs to be created. So for example, you may be doing considerable work with the field teams and with the national staff and with the various different constituent communities, right? But it may in fact be helpful for you to know that somebody somewhere has already developed a technical protocol, right? That specific subpopulations should be required to follow in order to go through the work of, in order to perform the actions of engaging a community, even if their initial disposition is not to, right? So sentiment doesn't have to govern everything, right? And proximity doesn't have to govern everything. There can be tools, techniques, procedures, protocols that can be implemented in order to realize certain kinds of outcomes that you wish to see. But in order to do that, anthropologists need a broader infrastructure of social scientists that they can draw upon in order to, find resources and tools, and then they can readily, locally adapt them very quickly so that they're situationally appropriate and fit for purpose.
Mitra first, and then the mic will go.
Yeah, I'll be quick. Just the anthropological remark that I do really agree with you that we need to build up some new anthropological capacities in anthropology of humanitarianism, and also new methodologies maybe. Well, I don't know if you have an idea about new methodologies in a case of crisis, for example. I don't know, I've never done that before, but I think it's one of the most difficult one, because as we are saying that as an anthropologist you need to have longitudinal studies on a communication or a field, and what happens in crisis cases. Yeah, and I do agree with you about this anthropological network in anthropology of humanitarianism too.
Yeah, thank you. I think that that's a great point. I think that I want to go back to the point that I made, which is that culture doesn't change, yeah? So as an anthropologist, I'm a bit fatigued, for example, with situations where the Zika epidemic emerges and suddenly everybody starts looking for studies on reproductive health in Brazil, right? People have been doing research on reproductive health in Brazil for 100 years, right? There should be ways to take existing research, existing literature, existing resources, existing experts, and create a longitudinal baseline, right? With scarce resources, with emergency conditions, the focus of formative research needs to be the emergency and the effects of the emergency. And much of the contextual details can be filled in from a wide field of existing research. I can tell you that there is a global community of regional experts, linguistic experts, and content experts that are desperate to contribute their knowledge to these sorts of situations. They don't want to be there. They're not really asking for much out of it. They're not necessarily looking for financing, but they want to see their research be used, right? They want to see it translated into action that helps people. The entire African Studies Association is keen. I mean, there's several thousand members of the African Studies Association in the United States, and then there's a European African Studies Association. I mean, there's several thousand experts that are keen to contribute their knowledge to the response. Excuse me. That we need to develop methodologies, pathways, resources, and networks so that that knowledge can be translated and used rapidly for really like the point person in the field. The anthropologist who's in the field should be the pointy tip of the spear, not the whole spear, right? And so we need to think about setting up a whole different range of capacities. If I can just, you know, deviate from the question a little bit, I recall in September of 2014, there was a call by the I think it's the ELRHA partnership, which is a humanitarian academic partnership program for research proposals to address the situation in in West Africa, the Ebola situation in West Africa. I was invited to join a multi-member team to submit a proposal. There was maybe 5 of us, yeah, who were included. Epidemiologist, demographer, anthropologist, public health expert, medical person, right? So we submit our proposal, and I recall 2 weeks later, we received back feedback that 25 awards had been given, right? But that there had been 250 proposal submissions, all with multi-member teams, right? And the remainder of the proposals that hadn't received funding were essentially told, thank you so much for your submission. We've distributed our funds. Go home, right? We have an enormous surplus global expert capacity on public health, clinical medicine, social and behavioral sciences, and regional and area studies. At least social and behavioral sciences and regional area studies should be engaged in order to help people. They desperately, desperately want to. And they should stop being told to go home.
Yeah, I have something to that, and perhaps to first.
Hi, I'm Justine. I'm HR officer in the e-desk. To me, I think anthropology is already starting to have a foot inside the operational response with the health promotion. But for sure, if like Doris start in Afghanistan to do studies about the relationship between patients and antibiotics, if we do it in Middle East, it might help us a lot, probably in our own response and how to treat people who always want antibiotics. But yeah, for sure, to me, health promotion is already a start, and this is something we didn't mention in this conference.
Sure. I'm a bit, I lack clarity about the technical language. I know that there's health promotion, social and behavioral change, social change communication, social marketing, social mobilization, community engagement, and then there's media campaigns and messaging, and it's like, and I understand that they're all interconnected, but I can tell you that, for example, in the World Health Organization's emergency response framework, social science interventions have been fitted under emergency risk communications with 5 other categories, including community engagement and media, for example. So I do see that they're making inroads. I think that what concerns me is that I think that that might not be, I think that it's important to have anthropological engagement in health promotion space, but I'm also aware, as most of you are, that in the countries affected by conflicts and wars, there's actually a growing, enormous population of highly talented community engagement workers who are locals, who are skilled at engaging with communities, who know the area. And I don't think that anthropologists should necessarily be competing for the community engagement slot, especially I also think, relatedly, that there needs to be a significant investment of resources in social science training programs in the countries that are most likely to be impacted by emergencies, so that those national intellectual resources can be engaged at that time. It shouldn't just be a question of somebody coming from London or Paris or Antwerp or Boston or wherever. But I think it's a good step. I think it's a pathway to engagement. I'm not sure that the issues that we're talking about, the need for technical development, training, protocols, standardized sets of expectations, all of this stuff, I don't know that that's factoring in. I think that the space of anthropology is something that's very appealing to a lot of people, and the space of humanitarian intervention is really attractive to a lot of anthropologists, but the mechanisms for bringing them together in ways that are going to be productive and helpful at the field level have yet to be developed. So we may see it in the health promotion space, yeah?
Yeah, just a follow-up to that, actually, kind of, because and that's something I touched upon a bit earlier. But you're talking about the need to create an infrastructure and organized community of practices, somewhat. But I go back to my comment about how many specialists from many different fields might want also to contribute to humanitarian action and feel that their contribution might be highly valuable. And I think that at MSF we are relatively open to those contributions, but there needs to be some sort of triage, or the access needs to be negotiated, because there is no way that our context of intervention can be the scene of a multiplication of intervention of all kinds. Mm-hmm. Despite the breadth of willingness and of volunteering spirit that exists out there, there needs to be some kind of way to actually organize these, filter it through making, the access to literature review easier, to kind of orientate, identify the resources that need to be tapped into. Again, the body of knowledge exists, you said it yourself. How much do we need a specific, crafted body of knowledge for what we do? I'm not entirely sure this is absolutely necessary in all contexts. And I'm struggling between these two imperatives of being open, but at the same time making the condition of the work in the field to actually do the work in the field that they need to be doing. Just with one last word, with teams that have proven to be historically relatively like pluridisciplinary, not expert in many things, but good at virtually everything at the same time.
Good at virtually everything at the same time. I think that the key is making sure that the team is fit for purpose, right? And humanitarian contexts are frequently changing and they're frequently evolving, and in one situation you may need someone who's really attentive to qualitative factors, and you may need someone who's a geospatial specialist. Sometimes you may need them in sequence. So for example, in the context of the Ebola response, you had anthropologists who were tracing out population movement patterns on the basis of urban-rural relations, political factors, and food supply, right? But they certainly couldn't map, right? So you bring in an anthropologist to put together, you know, a summary, yeah? Like a formative document that essentially says these are the patterns that you want to look for, geographers. Bring in the geographers to do the mapping to identify inflection points, yeah? And then you mobilize your health promotion teams to go out to these inflection points in the context of a geospatial situation, right? And you know, you have a far more precise response than the sort of scattershot distribution of messages and outreach and engagements and whatever that currently exists. You know, one of the dynamics that I observed in Ebola was that messaging sort of either was like snowfall and it covered everything, or it was like a bullet and it hit one community, yeah? And I think that what we need to do when we're talking about using the knowledge and the capacities of anthropologists, we're talking about the systematic deployment of qualitative information in ways that can work interconnectedly with other fields. But of course, that's going to require effort, yeah? Instead of saying, you know, I'm an anthropologist and I lay claim to this space in this context and you go away, yeah? We need to understand that everybody brings resources to the table. We're all better for coordination and cooperation, but you can't just have a scrum of people coming together. You have to have systems to make sure that information is feeding between, you know, knowledge type and knowledge type in ways that make operations effective and help people. And I mean, that needs to be ultimately the gold standard for determining whether or not this whole suggestion works or not.
Thank you. Any more question? Last one before I close? No. All right. So I will close. And as I've learned now for doing these exercises for some time, I'm not going to do any wrap-up. So I leave you right here with the apéro just behind you. Just one small note in a way of a conclusion, because l'occasion est trop belle actually to do that. It's the first time I think that I can announce you already the next conférence du Crunch, which will be held on December 5th, a Tuesday, and there will be we'll discuss the politique vaccinale with Lise Barnéou, who's recently published a book that's called Immunisé. So come back. And on that note, I thank you very much, Sharon, for being here again, and all of you for your engagement. Thank you very much.